Hello, and welcome to the 9th week of the Henry Schein webinar series on COVID-19. I'm Dr. Gary Severance, and as we normally do, we want to go right to Dr. David Reznik with his clinical update for the week. Dr. Reznik?
Thanks, Gary. It's always good to be back with you to help with an update on what we're seeing with COVID-19 as we move further, as we see some offices starting to open. And what I thought I would do today is talk a little bit about where we are with the epidemic and some overall symptoms, kinds of things that you'll be asking when your patients before they come in, and maybe on your medical history form or your COVID screening form. But I thought I'd start off with where this epidemic is in the United States. And if you look at the light brown, you can see low incidence growth. The darker brown is an elevated incidence growth, and then the darker purple is elevated incidence plateau. Now, when you see the colors start to lighten up, then you're seeing sustained decline. You're seeing low incidence plateaus. You have some where there are no reported cases if it's completely white, or zero cases, very light gray in the past 2 weeks. So we're seeing this is truly impacting all of us. It's impacting how we do our business. It's impacting how we provide safe and healthy care for those we serve. Since we are doing some triage on the phone and we are wanting to check our patients for symptoms, since we don't have a point of care test at this point that is reliable, we have to go by symptoms and travel questions and things of that sort. So here's a little bit of a repeat that the symptoms start between 2 and 14 days. You would have a fever greater than 100.4, shortness of breath and difficulty breathing, dry cough or chills, repeated shaking with chills, muscle pain, headache, sore throat, and then we did talk about this before, the loss of taste and smell. I thought I would take it one step further, not to scare anybody, but just to let people know what we're seeing among acute signs and symptoms on admissions in hospitalized cases. So fever and chills, which makes perfect sense. Whenever you've had a fever, you have the chills, you know you don't feel well. Muscle aches and myalgias usually goes along with fever. Then we have diarrhea, nausea, vomiting, headache, chest pain, altered mental status, abdominal pain, etc. The respiratory signs, cough. And cough is one of those things that doesn't clear up quite as fast as the other symptoms. So you might have some folks who actually clear with their temperature, 72 hours, no acetaminophen or no aspirin or no ibuprofen, and the temperature goes down without that, but they still might have a residual cough. Shortness of breath, very high on what we're seeing in the hospitals, congested runny nose, wheezing is one, and a sore throat. So I just wanted to give you some of the signs and symptoms of what we're seeing on serious cases as they go to the hospital. But on a more positive note, there's been a great deal of news on research lately that has been happening. We had remdesivir. It's a medication, an IV medication made by Gilead Pharmaceuticals. I'm actually very familiar with them because they've been in the HIV market for years, and that's what I work in. But 1,000 COVID-19 patients were treated with either remdesivir or placebo. So you either got the medicine or you didn't. The remdesivir patients spent less time in the hospital overall, an average of 11 days to 15 days compared to 15 days. So that's great news, because one of the issues we're having, as you know, is our ICUs are getting a little bit overwhelmed and our hospitals are getting a little bit overwhelmed in some of the hot spots. There was no significant difference in mortality, but a positive trend. If it was less than 0.5, we could say that there was some significance, but at this point it's just trending that way. But Dr. Fauci, who I have had the pleasure of working with in the past, when I was on the Presidential Advisory Council for HIV and AIDS, he is quoted as saying that data shows that remdesivir has a clear-cut, significant, positive effect in diminishing the time to recovery. Most folks are looking at this as a part of combination therapy in the long run as we move forward, and the FDA is moving with remarkable speed. I will say that during the first pandemic I dealt with on HIV, the FDA was not something you would see speeding things along. But right now, we're seeing the FDA move at remarkably fast times. So, what are the CDC recommendations for people who test positive for COVID-19 and are in need of emergency dental care? So people with COVID who have completed home isolation clearance, and I just sort of mentioned that, can receive emergency care. So this is defined as 3 days or 72 hours without fever. Now, they still might have that cough. That's why I was bringing that up. Or at least 7 days have passed since the first symptoms have occurred. For individuals with lab-confirmed COVID-19 but are asymptomatic or pre-symptomatic, had at least 7 days have passed since that first positive test and no subsequent illness, you can treat them. But how you treat it always is going to involve using N95s. Then, other good news. And so I really want to stress some of the good news that we're seeing. Roche wins the U.S. nod for a COVID-19 antibody test. So this is good news. It was an emergency approval to determine whether people have ever been infected. And that's the key, is have you been infected with this coronavirus or not? The antibody test has a specificity of exceeding 99.8% and a sensitivity of 100%, meaning the test would have very, very few false positives and no false negatives. So just as a repeat, because let's be honest, I had to look it up, sensitivity is the probability that a test will indicate disease amongst those with the disease, and specificity is the fraction of those without disease who will have a negative test result. So the Roche test is remarkably accurate. You also might have heard, now please understand that the Roche test does involve a blood draw, which has higher accuracy than finger prick tests or saliva-based testing. Although in our field, if we could get a finger prick antibody test or saliva-based antibody test, we really would be in great shape. Abbott also has a test out there, and their specificity and sensitivity is 99.5 and 100%. Again, another remarkable antibody test. And there's a company I don't have any familiarity with that does have another test out there, and these are the three that people are using in hospital settings. But as the demand escalates, there's a lot of folks out there who have no background in this kind of market who are trying to get these antibody tests out there. So please use the blood draw test. Don't use some tests that are coming in, because a lot of these things are counterfeit, or they haven't gone through the testing process. And since I'm talking about counterfeit just for the moment, please make sure when you're buying your N95s that you are buying the real thing, that you are not buying counterfeit, because on the CDC's website there's a whole list of counterfeit N95s and counterfeit KN95s. These are the two most popular respirators that we use. So please make sure you're getting the real items and not counterfeit items, because we're seeing a lot of that come into our country. What does a positive antibody test mean? And that is the $10 million question. At this point, actually $10 trillion question. Governments and businesses and individuals are seeking these tests to learn who may have had the disease and who may have some immunity and maybe some strategies. The bottom line truly comes here is, does the antibody test mean that you have immunity? And the answer is, we don't know. I mean, you might have immunity. You might have immunity for a period of time. You might have full immunity. The question is, we just haven't been able to study it long enough, because remember, we really started dealing with this at some point in January. We're just at the very beginning of May. The speed in which the systems are moving is pretty impressive. So with all that good news, we have some more guidance to follow. And I'm not going to go into the details of OSHA, because, well, let's be frankly honest, there are some wonderful people I work with who are really expert in OSHA. They teach, they do certification in OSHA on an annual basis, and they really are wonderful speakers, wonderful authors, wonderful professionals. But I did want to go over some of the highlights on an OSHA interim guidance in dealing with COVID-19. So they look at different levels of risk. And so if you look at the lowest level, you would be performing administrative duties in non-public areas of a dental office. So it could be the insurance office, you're in the back, or, I have had some back problems and some back care. The lady who does the scheduling, who's one of my favorite people in the world, she's hidden in the back now. I don't see her, and she's not at risk, which is a shame because I really do like her. But she's in the back, and she has low-level risk. Medium risk would be providing urgent or emergency dental care not involving aerosol generating procedures. So again, we're dealing with this aerosol issue. To well patients, to general members of the general public who are not known or suspected to have COVID-19, or medium risk is also working at busy staff work areas within a dental office. I mean, a lot of us have multiple staff. There might be break rooms, and so we really need to follow some physical distancing, hand washing, all of those wonderful things that we've been doing that will hopefully reduce incidence of COVID and incidence of influenza when season returns. If we look at high level of risk per this interim OSHA guidance, high level will be entering a known or suspected COVID-19 patient room or care area, so that is basically more hospital associated. Providing emergency dental care not involving aerosol, so not involving aerosol generating procedures to a known or suspected COVID-19 patient. So just being in the room, because remember, coughing produces an aerosol. Talking produces a minor aerosol. So things that we don't normally think about, like the hand pieces and air water syringes and ultrasonic, all of that, of course, but just being in the room. So that's considered high level if you're performing aerosol generating procedures. What does that mean? N95, and we'll get there again, or KN95. Very high is performing aerosolized generating procedures on known or suspected COVID-19 patients, so that's a remarkably high risk, or collecting specimens. And if you've had your COVID test, which I did, I'm proud to say our hospital has been doing routine screening, and at this point, less than 1% have been positive, which is great news. So OSHA guidance on non-aerosol generating procedures. What they want is a combination of standard precautions that we've all been doing for decades at this point, contact precautions and droplet precautions. And this includes eye protection. The glasses I have on now today so I can look at my slide, this is not considered eye protection. I have to have something over your regular glasses. So goggles or a face shield. I wear a face shield so I can see. So that protects our dental workers when we're performing patient care. That does not involve aerosolized generating procedures on individuals without suspected or confirmed COVID. OSHA guidance for aerosol generating procedures. In emergency situations when workers have exposure to suspected or confirmed COVID-19 patients, and then I highlighted this, in any time when performing aerosol generating procedures, the use of standard precautions, contact precautions, and airborne precautions, as well as eye protection to protect. So anything we use that involves dental turbines, micromotor handpieces, ultrasonic scalers, etc., air water syringes can generate aerosols. And I don't have an entire list of things that can produce aerosol, which is why we really have to take care and be aware. So what does that mean as far as engineering controls? In dental offices that can create negative pressure rooms, which there aren't very many, or you can use local exhaust ventilation to capture and remove mists or aerosols generated during procedures, that's fine. If not, there is equipment that does help manage aerosol production in the dental setting. I highly recommend you talk to your representatives and do your homework on that. This is a new area. There have been some equipment that's been out there dealing with amalgam aerosol, but this is new for dentistry and how we work with it. So please work closely with your sales reps and do your homework on these. If possible, use directional airflow, such as from fans, to ensure the air moves through the staff work area before patient treatment areas. You don't want to blow the aerosol towards your staff. You want to have the fan hit your staff and then blow it in a different direction. Some administrative controls that were mentioned in the OSHA update. Use telephone triage. That's why I went over the symptoms earlier in today's presentation. And travel check. Have you been to high incidence areas? Have you traveled to a high incidence country or high incidence part of the United States? Use teledentistry when it's possible for non-emergency patients. Please stay in touch with your patients. The ADA letter I referenced last week is a great way of staying in touch with your patients, but any way that you can keep those folks that have depended on you for the care for all these years, you want them to know that you're still out there and that you will be started or you have started, and things will be a little bit different. When emergency care must be provided to a person with suspected or confirmed COVID, restrict the number of people in the room. Whenever we're doing aerosolized procedures at this point, we're going to restrict the number of staff that are actually in the room, including residents. So we really want to minimize aerosol generating procedures. We want to minimize the number of people who are involved during the procedure. As far as safe work practices, when performing emergency dental care workers should follow all appropriate precautions for dentistry and healthcare workers, as well as ensuring you're still following those bloodborne pathogen standards, because we deal with a lot of saliva and a lot of blood. If aerosol generating procedures are necessary for emergency dental care, always use high-speed evacuation, and you can use dental dams to minimize droplet spatter and aerosol, as well as the extraoral aerosol vacuums and air scrubbers and things of that sort. As far as the OSHA safe work practice, perform as many tasks as possible away from the treatment room. So I know we have computers in the treatment room, and we do a lot of documentation in the treatment room, or we have paper. Remember last week I talked about not having as much paper in the dental room. Well, let's do our charting and our cleanup as fast as we can outside of the treatment room so we can do our proper turnover and make sure we've done everything we need to do. It's very difficult, but workers should avoid touching their faces, including their eyes, nose, and mouth, which we do a lot every day. Having the mask on, I will be frankly honest, has limited the number of times I touch my face, which is sort of fascinating. And washing your hands for that 20 seconds. I've already started to notice that people are going back to that old habit of happy birthday as fast as they can and they're done. So it's really hand hygiene for us is remarkably important, and especially important after removing your personal protective equipment. Speaking of personal protective equipment, I've listed out here, or actually borrowed from the OSHA update, what we do for well patients and patients with suspected or confirmed COVID-19. I want you to look at the part that says dental procedures that may or are known to generate aerosols, gloves and gown and eye protection like I've talked about, and then a NIOSH certified disposable and not a fake, a real N95 or KN95 filtering respirator or better. So that's where if you have aerosols, you need a face mask, a surgical mask if you're working with a patient and you're not going to be involving aerosol generating procedures. For patients with suspected COVID-19, please note that N95 filtering is on every category, whether there is an aerosolized procedure or not. And you know, we've always, honestly, we've always treated all of our patients in standard precautions as if they had a bloodborne pathogen, realizing that a very few percentage of our patients do have a bloodborne pathogen. It looks like our standard behaviors are going to change, and that we'll be wearing more N95s, doing routine exams than we would. It's going to be a change for all of us. Our goal through these webinars is to make it easier, or at least help with the transition. I hope today's information has proven helpful, and I look forward to your questions. So Gary, back to you, and thanks once again for having me on this webinar.
Thank you, Dr. Reznik, for that informative update. We look forward to your input each week. Now I'd like to turn it over to a renowned dental design expert, Dr. Mark Tholen. Today, Dr. Tholen will review the real and perceived cross-contamination threats in your dental office and how to communicate your safety measures effectively to your patients. Dr. Tholen, thank you for joining on what is a beautiful day in Dallas, where we both live. Welcome.
Well, thank you so much, Gary. I really appreciate that introduction, and I'm really happy about being here today. We're going to be talking today, obviously, of how we can work to be able to use the idea of space management to minimize the real cross-contamination risks in our practice, as well as minimizing the perception of microbial risk to our patients. When we think about delivering dental care, we really all consider four necessary elements. One is just the stuff, okay? We have to have equipment, we have to have instruments, so in order to do the procedures. We also think about staff, and of course we have to have individuals working in the office to support us. We need space, that is to say we have to have something for an office. And then finally, we have to have system protocols, which is procedures. I mean, how is a procedure to be done sequentially? What are the steps ad infinitum? So the one element we spend the least amount of time thinking about, though, is space design and utilization. And so that's what we're going to talk about today. That's what we're going to examine today. And how do we effectively use space in our existing offices to minimize the real cross-contamination risks while enhancing our patients' perception of microbial safety. And I think that that's really key to this presentation. We're using space to reduce the real cross-contamination risks while enhancing our patients' perception of microbial safety in our offices. So in order for us to really think that through, we're going to begin talking about space utilization with the topic of architectural zones. Now, architectural zones are nothing more than groups of light-purposed rooms. In other words, where the clinical care is actually accomplished, all those rooms are grouped together, ideally, into a clinical zone where the public is essentially able to move alone and unaccompanied. We're calling that the public zone. All those rooms will group together. And finally, we have a staff zone where the staff traffics without any patients. And so those rooms are called the staff zone. And every facility that has any functionality in the world has zones, whether it's a church or whether it's an airport or a train station or a hospital or a dental office. We all have architectural zones. Now, the zones are different in a restaurant as opposed to a grocery store, as opposed to a hospital, but they all have zones if they're attempting to accomplish a very specific function in that space. And in our dental office, we have three zones: a clinical zone, a staff zone, and a public zone. And so we're going to try and segregate our spaces as best we can into these three zones. Now, let's take a look at the elements in each zone. The clinical zone is going to include the operatories, central sterilization, the lab, a finishing and polishing lab, and X-ray or radiography. We want to group those rooms together if at all possible. Then we have the public zone, and that's going to consist of a reception area or waiting room, the business area or front desk, a patient restroom, and a consult room. And I have a comment to make about the consult room while we're here. The consult room is where we present our cases, where we do a case presentation, where a treatment plan is offered to the patient. I'm suggesting we don't do that in the operatory. The operatory is it's a doing place. That's where we actually treat the patient. We lay hands on them. Here, we're going to talk to them and we're going to inform them. And we want to have tools or equipment that allows us to convey the concept of the treatment that we're offering. And honestly, I wouldn't do that in an operatory. An operatory is the most expensive real estate in the entire office. Get people out of the operatory if they're not going to be treated, and put them in a less expensive space, which would be the consult room, which would allow us to effectively communicate the kind of care that we're going to provide to the patients. Now, nobody is going to decide on a $12,000, a $20,000, $30,000 treatment plan in 5 minutes. And that's what we're trying to get them to do if we're in a operatory talking to them. So the best thing to do is to have them in the consult room. We're talking with them. Our office manager or the individual presenting the treatment plan is talking with the patient. And then if you are in the console room at the time, you can simply excuse yourself at an opportune moment after all of the treatment plan has been presented, and then the office manager or the case presenter can complete the transaction. So just a couple of thoughts about the console room. Also, the treatment area is more contaminated than the console room or the public zone. So we would like to get the patients in and out of that more contaminated area as fast as possible. Now let's move on to the staff zone. We also have a staff lounge and staff toilet, your office and toilet, a mechanical room, and bulk storage. Now, the lab that I've indicated in the staff zone is a production lab. The production lab it exists for prosthodontists, ortho and pediatric offices for the most part. But the production lab has full-time lab personnel working in there. And for that purpose, we put the lab in the staff zone. The lab that is in the treatment zone is a finishing and polishing lab that is used by staff quickly to and from the operatories. Let's also think about the movement of the patient through the office. And I'm going to be suggesting that obviously we have a patient entrance through the waiting room, and hopefully we have a staff entrance that is separate and apart from the public or patient entrance. In this age of the virus, I think it's important that we try and move our patients through the office a very efficient way, and not have them retrace their steps and be re-exposed to people. So if we have people waiting in the waiting room to come back for treatment, let's think about having our patients actually exit through the staff entrance rather than going back out through the waiting room. Now let's take a look at a real floor plan and see how the zoning actually works and how it actually works to help us minimize cross-contamination and the perception of enhanced microbial safety. Let's see, here's the public zone. You can see the waiting room and reception and business area, consultation are all together, as well as the patient restroom. And you can see the patient restroom just below the appointment desk or reception area there. And it has the icon of a toilet and sink. And it is in the trunk hallway communicating the public zone to the operatories. And the reason that the toilet, the patient restroom, is not in the waiting room is we want to be able to manage who goes in and out of that restroom. We want to see who's going in and out, and make sure that whoever goes in does come out, they don't faint or something, and that they and that the staff can actually view the restroom door, so that when anyone comes out of the restroom, then they're able to go in and clean the restroom for the next patient who may be using that space. Also notice that that entire zone now is grouped together, and we're sequestering people and in essence, the clinical zone from that public zone. Now, the public zone is separated with that trunk hallway that communicates from the essentially reception area down to the hallway, the treatment hallway, where the operatories are located. All the ops are together on one wall, and just to the right of the operatories is the lab. Then there is, if you look across from the operatories, there's central sterilization, there's radiography, and there is a high-tech parking lot. I'm going to suggest that another way to minimize cross-contamination is to not store any of your larger equipment or things like lasers or endocarts or optical impression devices. Don't store those in the individual operatories, but put them in the high-tech parking lot. That way, when staff members need the unit, they're able to go to the high-tech parking lot. They know the device has been decontaminated, and they're able to take it to the operatory where it's needed. If you have these devices and they're just simply staying in the operatories, they're being constantly bombarded with the aerosols and the particulate matter from a particular procedure. So let's get them out of the ops. Let's get them into that high-tech parking lot. And so we are confident that every time we take them out of that high-tech lot into an op, that they are indeed at least clean. And then we have the staff zone in this particular floor plan on the left-hand side. The doctor's office and restroom is in the lower left corner. The staff lounge and restroom is just above that. And then there's bulk storage just to the right of the staff lounge. So we've got all of the staff zone located together. Each segmented zone stands alone, and this way we minimize the potential for cross-contamination. So now let's just take a look at the public zone for a second and see what we can do there to minimize our cross-contamination. One of the first things that you'll notice, this is in the gray area. The gray area has the waiting room, it's got the consult room, it's got the front desk, and it has the patient restroom just off to the left there. So we're going to have these four elements of the public zone, and we want to be able to make our patients feel comfortable. So if they're sitting in the waiting room, let's either remove every other chair in the waiting room, or let's place some type of notice on every other chair that it's not to be used for the immediate future. Now let's take a look at the reception desk and the appointment desk. You can see in this image, the reception desk, which is on the right, is completely separated from the appointment desk. And so the patients are checking in there, just announcing their presence, and they're having a seat in the waiting room, while at the appointment desk, patients are being reappointed. Now, in this example, there are permanent partitions that are segmenting the appointment desk. However, if we just have one long appointment desk currently, then I'm going to suggest that you may want to suspend some plexiglass plates from the ceiling and segment the appointment desk as you see here, but with plexiglass, so that we're able to give our patients a greater sense of microbial security. Another big item, and even though it doesn't sound like a big item, it actually is
If we're able to use floor cues, if we're able to constantly remind our staff as well as our patients to maintain the physical distancing, that's a big deal. And we can either be using notices that are vertical, or we could actually be using taped notices that are on the floor. Please stand here. Please wait here. But what many people are finding out, especially in the most hard hit areas, if we have very adequate signage, it's a big help for the staff to constantly remember, and also for the patients. Now let's begin looking at the clinical zone and seeing what we can do inside the clinical zone to abate the problem of cross-contamination and to enhance our patients' perception of microbial safety. And you'll notice in this particular example of the zones, the clinical zone is in green. All the operatories are together. Sterilization is opposite the ops. The lab is next to sterilization, and radiography is not labeled, but it's at the end of the clinical hallway in the little alcove off to the right. And so we've got all those elements together. The reason we want to try and compact the clinical zone is this is where all the aerosols are being created, either in the hygienist's treatment of patient or in active dental procedures. And so how are we going to be able to manage the aerosols in this environment that we all know so well? The environment is small, it's very compact, but we create a lot of aerosol, and particulate matter begins to float and then settle on hard surfaces in and around the operatory. Now, let's think about utilizing some of the techniques and the technology from other professions, from the medical profession and from clean rooms and from research labs. How do they manage the problem of particulate matter and aerosolized drifting all over a room? And the answer is that they use negative pressure systems. And a negative pressure system is nothing more than just what it sounds like. The air will not leave a room with a negative pressure system. And what happens is that the air is actually filtered through a HEPA filter in the negative pressure mobile unit that you see here in the corner. So that air is moving into this room, but it never leaves the room, okay? And that is very important for the management and control of the virus in a particulate or aerosolized format. Now, the emergency room and the hospitals will use a negative pressure room or a mobile negative pressure unit whenever they have to do an aerosolized procedure. Something like using a nebulizer on a patient, being able to intubate a patient, doing a bronchoscopy. All these things require a negative pressure room or a negative pressure mobile unit because they don't want to cause cross-contamination. Here's a close-up of an example of a negative pressure unit. You can see this on the internet. You can do a search and you can find them. There are a number of them. This one is called AirX, but they're HEPA filtration machines, and so they're highly efficient, and the air is coming one way. It's coming into the op or into the exam room or the treatment room. It's not leaving the treatment room. Now, what I and my architectural team are doing at this point is we're spending a great deal of time on looking at how we can retrofit dental offices for negative pressure rooms or negative pressure HVAC systems and or mechanical systems within the office. And so that's a rather extensive effort. We're working through it in real time. We're working through it with offices that we're designing right now so that we're incorporating negative pressure into some of the operatories. Also, we're in real time. We're working with retrofitting certain offices, especially offices that require treating emergency patients like oral surgery and endodontics. And then we're also working in the transfer of all this information and technology as we glean from researching clean rooms and in hospitals and negative pressure rooms in ERs, as well as research laboratories. So at the end of this month, we're going to be broadcasting an entire program on managing air quality in the age of the virus. Maybe you'll be interested in watching that. Beyond the use of negative pressure, there are some other things we can think of inside the operatory. And one of them is the personal protective equipment. I'm going to suggest that we're going to be using gowns so that we minimize the amount of exposed skin in the operatory, because again, almost every procedure we do involves aerosol. We want to obviously be using a mask. I'm going to suggest that we all want to use N95 masks. Now, an N95 mask is going to protect you, and it's going to protect the patient. It's going to filter out all the viruses and all of the bacteria and all the mycobacteria. But a surgical mask is going to protect the patient from your exhalation and what you have in your lungs, but it doesn't necessarily protect you from all the aerosolization. So if we have the N95 mask, that is ideal. I guess something's better than nothing, but indeed that's really a necessary part, and that's what all the hospitals are using. And I know that I just saw a news release yesterday that said that Honeywell is now making something like 1 million masks either a day or a week of the N95 version. So we can hopefully see that in great abundance in the very near future. Another item that we want to use is safety glasses. So either eyeglasses or safety glasses. Safety glasses are even better because they fit snugly around the entire face. And I'm also going to suggest that when we're wearing gloves, if you're using exam gloves, you want to change the exam gloves at a maximum of every 45 minutes, because exam gloves are supposed to be just that. They're exam gloves. They're not surgical gloves. And so after 45 minutes or so, the latex begins to break down in exam gloves. Are not made for long-term use. And if you have anything going on for any length of time, you're going to want to use surgical gloves. And I'm also going to suggest that we're using some kind of head cover. Now, in this particular photo, the staff is not using a head cover, but I would recommend that if you're concerned about aerosolization, and also some shoe covers. You can just wear those on all day long and then take those off at the end of the day. The idea being that our shoes are not contaminated now, because if you think about it, if we're using aerosols in the operatory, anything that's not covered and anything that we're not taking off and washing is going to be contaminated. So Anything that we can do to cover ourselves is a plus. And then finally, the last thing that all of us are doing now is using a high-speed suction. And I'm going to suggest that we use high-speed suction also in the for the hygienist, and because it's reducing the aerosol. And if the hygienist is using ultrasonic scalers or piezoelectric scalers, for heaven's sakes, that we've got a tremendous amount of aerosol there. If we had a high-speed suction, it's such a help. And if we're using a hygiene assistant to help and work with our hygienist, I would say that if you explain this in an email to your patients or in some type of notice in the waiting room, I'm almost certain that at least on the short term, every patient's going to appreciate the idea that we have the additional personnel to help out here, and to be sure that we're safe and that we're minimizing the aerosols in the entire office. Okay, we've looked at what's happening or what could be done inside the operatory. Let's look at sterilization. How can we rearrange the space in sterilization to enhance the perceived safety, perceived microbial safety of our patients, and at the same time we can create a actual or real minimization of cross-contamination. The first thing I'm going to suggest is we try and set up our sterilization area so that we're going from dirty to clean to sterile to storage. And so that means either in a clockwise or a counterclockwise fashion, we're moving through the process from dirty to clean to sterile to storage for a very defined instrument cycle flow. In this example, we have a galley style sterilization unit, and the dirty instrumentation is placed immediately to the left of the entrance, and and it's processed and cleaned so that at the depth of the left side, we would just simply have clean instrumentation. Then it would be wrapped or bagged, and it's going to be put in the autoclave on the far right back part of the image, and then it's going to be autoclaved, and then finally, as it's sterile, then we're going to store it in these vertical towers that you see that are nearest to you on the right side of the image of the galley style sterilization area. And you can see that in the graphic off to the right, the operatories are all together. They're on one wall, and sterilization is in opposite those operatories. Notice the clinical hallway. The clinical hallway is, patients are walking up and down that clinical hallway, and your staff is probably not going to, if there is a door on sterilization, they're not going to close it. The average clinical assistant will go into sterilization 80 to 100 times a day. I know this because we've counted it numerous times with and in offices as we watch the movement of staff members from one area to another. So they're not going to close a door every time they walk in or open a door, and they're going to prop it open one way or another. And so the staff, the patients are going to be seeing what is going on here. And they're going to be looking in the sterilization, and we want to make sure it's very, very clean. And so we're going to have a very defined way of doing that, going from dirty to clean to sterile to storage. Now, you might think that is a very simple concept and that everybody's employing it. Well, no. In fact, it's not employed all that often. Here's a beautiful sterilization area, but let's see how it was actually set up. The dirty instrumentation comes in off to the far right, near that, just to the right of that dishwasher, and it's stored on the countertop. then is taken over to the ultrasonic cleaner. You can see the ultrasonic cleaner cover is upright now. It's silver looking over there, and kind of at the back of the sterilization area. And the instruments are debrided in the ultrasonic cleaner. Then they're taken out of that. They're moved back over to be rinsed in the sink, and then they're placed in the dishwasher to dry. And you can see the white dishwasher underneath the countertop there on the right. So you can see how things are ping-ponging back and forth. And once the instruments are taken out of the dryer, out of that dishwasher and the drying cycle, then they're taken over to the wrapping drawers that are just to the right of the bottom autoclave. Now they're wrapped and they're finally going to be put in the autoclave, but they ping pong back and forth between the wrapping area and the ultrasonic cleaner area over to the sink and over to the dishwasher for the drying cycle. So the potential for more cross-contamination is tremendous here. And finally, everything goes into the autoclaves. So again, the idea of creating a defined instrument cycle flow is not all that simple. You know, concepts are simple, putting things in practice, not so much. So how do we actually make our facility, our sterilization area, actually look really clean? Well, the way I'm going to suggest is that we're going to place our dirty instrumentation in these upper cabinets that you see. And I've colored 2 of them red. And so that indicates contaminated area. So I want to try and keep all of our dirty instruments up there. And then as staff has time, they come in, take those dirty instruments and place them in the ultrasonic cleaner, or they place them in the instrument washer to begin the processing of the instrumentation. But we keep the countertops looking very, very clean and neat because our patients are walking past here. And if they see a dirty, messy sterilization area, they're going to become very alarmed. So we're going from dirty, and you can see that on the with the dotted line. Here we go from the dirty breakdown area, and we're progressively moving to clean, and then to sterile, and then to storage. Now here's an example of a sterilization area that's been turned into a showcase. It is a proof source showcase that is saying to the patients, we care about you, we're very, very concerned, and we are really paying attention to the entire problem of sterilization and instrument management. Now, in this particular example, this is a built-in glass wall. So I'm going to suggest that in your office, if your sterilization area is open and visible to the patients, that perhaps we think about putting a plexiglass plate barrier suspended from the ceiling between the sterilization area and the clinical hallway. And so we're turning the sterilization area into a space that says, okay, you don't come over here, but it also says this area has been cordoned off, it's closely and carefully managed, and you can see that we are being scrupulously clean. And so you notice here, nothing is on the countertops. And this is the way it works on a daily basis in this office. And the assistant who was actually taking a tour of different doctors through the office said, it's easy to be organized when you have adequate space. Here's another example of a sterilization area that is on the treatment hallway, and it has been turned into a proof source showcase. And again, we're just going to make sure that the dirty instrumentation is placed in the upper cabinets. And if you don't have upper cabinets, think about creating space in lower cabinets. so that the dirty instrumentation is never out. And we're not trying to break down trays in front of people. The trays simply go into either the upper cabinet or the lower cabinet, and they're broken down when a staff member has the time to go in there and adequately process everything so that nothing is left on the countertops. I'm also going to suggest that you consider using cassettes, stainless steel cassettes that are color coded. And, you know, this is just a great a tool for instrument management in an office, because we can, your assistant can be wiping down the instruments as you're finishing the procedure. All the instruments are then placed in their proper sequence back in the cassette. It's closed up, it's taken into sterilization, and it's either placed in the contaminated cabinet, or it's placed immediately in the ultrasonic cleaner or the instrument washer. And I'm going to suggest that we're using tubs and for all of our disposables, and that those tubs are stored in the side cabinets of the operatories. And tubs for general practice office, we're going to have at least 50% of our cases are going to be either crown and bridge or operative. And so we would have those tubs, those operative and crown and bridge tubs located in the side cabinets of the operatories, while for all of our specialty tubs, those would be located in sterilization, and they would be brought into the operatories on an as-needed basis. Then we have the, my other recommendation in sterilization is to consider an instrument washer. An instrument washer is a fantastic time-saving device, in addition to being just a safety issue, because again, we're going to minimize the chance of cross-contamination. We're going to minimize the chance of punctures with the use of a cassettes and the instrument washer. And here's just a graphic on the sequencing of our use of sterilization equipment. If we were using cassettes, or even if we just have loose instruments on trays, we bring in the instrumentation on the upper sequence. We bring in the instrumentation, they go into the ultrasonic cleaner. They then are rinsed, and then they're air dried. I've done quite a few time in motion studies, and one of them was on the use of cassettes and instrument washers versus just using loose instrumentation and the ultrasonics and cleaning the instruments, rinsing them and drying them. What we found was we save 1 week of one assistant's time per month in the average 6-op office. That's huge. That's huge. And when you think about that, that means the staff members can be working with you in the operatory rather than being preoccupied in sterilization, which means you have greater productivity, and just our days go better because we have more assistants. To say nothing of the fact that we're saving quite a bit of money over a long period of time, even though we've purchase the instrument washer and the cassettes, that's a fixed cost, but the variable cost of the staff member goes on and on and on as long as we're practicing. So we come out way ahead financially if we use cassettes and an instrument washer. And here's just an example of a cabinetry that is designated as contaminated or for dirty instrumentation, and an instrument washer. So everything goes in the upper cabinets until a staff member has the time to come in, take all the cassettes or instrumentation out of the upper cabinets, put them into the instrument washer, and then process them. Now let's move on to the lab and take a look at that for just a second. We have the lab in the clinical zone, hopefully, and if it's not there now, let's try and get it there. One of the biggest mistakes that so many offices make is that they think that they're going to combine functions into a single space and it will be more efficient. Well, that's not true. It's just the opposite. Okay. If we want to maximize our efficiencies, we have one space per function. So in this example, it's kind of a almost comedic image. We have on the far left the model trimmer. So there's the lab. Just to the back left, near this wall that you see, there is a compressor and a stacked compressor and vacuum. So there's the mechanical room. On the far back right side, you see an autoclave. And in the very foreground, you can see the top of a refrigerator and a coffee maker. So there's the break room. So we got the staff lounge, the sterilization, the mechanical room, and the lab, all in one space. No, that's not enhancing our efficiencies. That is dramatically reducing our productivity. One space, one function in order to optimize production and to minimize stress. Now, in the lab, I'm just going to suggest that we have a very defined procedure for managing impressions, and we have a dirty area and a clean area in the lab, and that we're rinsing off our impressions to remove any debris, and then we're spraying them with a disinfectant, and then we're placing them in a bag for transport to the lab. And the lab's going to have their own process of cleaning those before they pour up the models. Here we have just a standard laboratory. The right side where you see the sink there, that's going to be the dirty side, and the clean side of the lab is off to the left. So our case pans or any of the appliances we're going to be delivering are going to be on the right, on the left side, maybe in those cabinets, and everything else is on the right side, all of our contaminated areas. Then I have one other suggestion for us, and that is in the staff zone. And specifically, it centers around a washer and dryer. Here's a photo of a staff lounge, and you can see the collapsible partition separates the table and the true staff lounge area from the wash area. The washer and dryer are immediately to the right here in the foreground. And what I'm going to suggest is the team is wearing scrubs, and at the end of the day, they change out of their scrubs and into their street clothes, and all of the clothing, office clothing, is washed at the office. And that way, the staff member's not carrying home any of the virus or bacteria that are on their clothes. One of the most common things that happen in hospitals is that staff members will take home staph infection, okay, and create staph infections on skins of their family members. So change at the office, and when you get home, don't have your family hug you or contact you to begin with. Take a shower immediately, and then you're able to have any contact with the family. But I think that would just be a very wise and prudent thing to do during this age that we're living in for the immediate future. Well, you can see that what we've been able to do today is try and optimize the utilization of space so that we can minimize the real risk of cross-contamination for our staff as well as our patients. And at the same time, we're able to minimize the perception of risk in the minds of our patients. We've discussed a great deal during this webinar. So I'm going to give you a couple of resources to refer to whenever you need some extra information. I have two books that I've written. Both cover a great deal of the information we have reviewed today, and a lot more, of course. So if you're interested, you can obtain those on Amazon.com. Additionally, you can send me an email if you have any questions at drmark@mynewdentaloffice.com. And lastly, as another resource for additional information, on my website, mynewdentaloffice.com, there are a number of blogs in the blog section, and they cover issues around remodeling the office, not specifically how do you manage air quality or how do you manage the rearrangement of your office during a kind of a viral outbreak such as we have now, but many, many related articles. So with that, I'm going to say thank you very much, and I will look forward to seeing you all again in a future webinar on air quality management and another all about the office facelift and reinventing your practice in a week.
Thank you, Dr. Tholen, for that great presentation. I love that high-tech parking lot and all the other tips that you provided. Now, based upon your chats, comments, and all of social media, we know the availability of PPE is at the forefront of everyone's ultimate concern. This past week, Henry Schein's chairman of the board and CEO, Stanley Bergman, sent a letter to the profession. In that letter, he answered the question, how will Henry Schein help to protect my health, my team, and my practice? He covered areas like commitment to protect your future, unmasking a market myth, practical resources, financing, and the supply chain. So please take a moment to review that. You can get access to it by the link in the description. As always, if you have any questions, concerns, or topics for future episodes, please let us know by emailing us at webinars@henryschein.com. And please subscribe to the Henry Schein YouTube page by clicking the subscribe button below. Thank you for your attendance, and as always, until we meet again, stay safe and stay informed.